Okay, so without further ado, I will turn it over to Dr. Sarah Smith, who is from the Center for Sexual and Gender Minority Health Research. I will stop sharing my screen actually so that Sarah, you can share your slides.
Perfect. Let me just open this for you. There we go. Looks good.
That
Um,
looks great.
awesome. Thank you. Yeah, big thanks for having me here today. Really excited to be given the chance to talk about some of the work I've been leading, and to be with all of you that are here. So thank you all for coming. My name's Sarah. I'm a postdoctoral researcher at the Rise Center for Queer and Trans Health Research in the Dalla School of Public Health at U of T. I've been here for about 3 years. My first 3 years I spent as a research associate, and now I've transitioned into being a postdoc. And this whole time I've been leading a project on 2SLGBTQ plus post-secondary student mental health from a sociological perspective. Before I begin, I do want to acknowledge that I'm speaking to you today from the University of Toronto, which is situated on Treaty 13 territory, the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island. I'm very grateful to have the opportunity to live and work on this land. In the context of 2S LGBTQ plus student mental health research, it's important not only to acknowledge the land, but to acknowledge the colonial violence that has been afflicted upon Two-Spirit, Indigiqueer, and LGBTQ plus Indigenous peoples, including historical laws designed to police and punish non-Western sexualities and gender presentations. These rigid Eurocentric binaries that were imposed through colonialism still impact Two-Spirit, Indigiqueer, and LGBTQ plus Indigenous peoples today. So we cannot think of mental health without thinking about colonialism, racism, and other forms of oppression. Before I begin, I'd like to also offer a little bit of a positionality statement. I approach this work as a researcher, but also as a queer person with lived experience of mental health concerns throughout my whole life. Perhaps more importantly, I approach this as a former student. I've attended 3 different universities across Canada, have engaged with mental health care services at each one. They've all been slightly different. They all have systems that have developed over time. In many ways, I was very grateful to find the help that I needed and very privileged as well. But in a lot of other ways, I did feel failed by these systems. So, I have this firsthand experience of what it feels like to be struggling in a university system where you don't always feel like you're actually set up for success. And the goal today is not to offer a wholesale critique of these systems, nor is it to talk about my own experiences. I just mentioned this as a way to explain why I wanted to take up this project, why this project is necessary, noting that this work is really grounded in like queer and trans students' experiences of what we're learning. And that's going to be the heavy focus of today. Today's presentation is very much an overview, some of the existing literature, some of my own work, and the sort of 4 key objectives are to explore key themes and topics within the literature on 2S LGBTQ plus post-secondary student mental health, to discuss the experiences of these students with on-campus mental health care, to explore some of the future directions for the work, based on the research that I've been leading, and to talk about some of the gaps that exist in this knowledge, as well as the significance of these gaps. A brief note on language as well. I'll be using a number of different acronyms in this presentation when I'm talking about my research, the research of other people. So the broad acronym that I'm using to frame this project is 2S LGBTQ+, which refers to two-spirit, lesbian, gay, bisexual, trans, and queer people. The plus is used to signify other identities that are not included in the acronym as stated. This include asexual, pansexual, intersex, and demisexual people. There's debates about the inclusiveness of these acronyms. We recognize that other people might use different acronyms than we do. So 2S LGBTQ+ is what we use at the center where I work. But of course, language is always developing. It's always imperfect. It's always changing. So always thinking about these limitations as well. And then if I'm talking about research of other people, I'll use the acronym that's relevant to their work. So if they're just talking about lesbian, gay, and bisexual people, I'll say LGB. I won't say the full acronym. That's not to be exclusionary. It's just to be faithful to the text. Also, I'll use the term we a lot. I know that I'm giving this presentation by myself, but I wouldn't be giving this presentation today if it wasn't for student research assistants, other postdoctoral researchers, faculty members, the students who participated in our interviews and our committee. So I really want to honor the fact that I did this work with a bunch of other people. So I will, sometimes I'll say I and sometimes I'll say we, and that's why. So the first major theme that I want to talk about today is about disproportionate rates of mental health concerns or mental illness or distress amongst 2S LGBTQ plus students. And while statistics vary between sources, numerous studies, the general consensus is that 2S LGBTQ plus students are more likely to experience mental health care issues than their cisgender and heterosexual peers. So broadly speaking, and this is not limited to just students, but the Canadian Mental Health Association gives us some statistics to help frame the scale of these concerns. So for example, 2S LGBTQ plus people experience higher rates of depression, anxiety, obsessive-compulsive and phobic disorders, suicidality, self-harm, and substance use. They're double the risk for post-traumatic stress disorder than heterosexual people. Of particular relevance to what we're talking about today, not all university students are youth, but many of them are. And so we know from the CMHA that LGBTQ plus youth face about 14 times the suicide risk and risk of substance abuse than their heterosexual peers. In an Ontario-based survey that they reference, 77% of trans respondents had seriously considered suicide and 45 had attempted. And trans youth and those who had experienced physical or sexual assault were found to be at the greatest risk. So related to student mental health specifically, I have some data here from the US and Canada. So in the US, the National College Health Assessment data from that survey notes that rates of depression, anxiety, and suicidality all rose between the years of 2018 and 2019. So this is some of the most recent data that we have. There's a survey from the Trevor Project in 2022 that found that 33% of LGBTQ plus students had seriously considered suicide within the last year, and that 7% of them had attempted. And then finally, data from the Canadian reference data from the National Health College Assessment, again, between 2013 and 2019, demonstrated very significant increases in challenges associated with stress, psychological distress, and diagnosable mental health conditions. And I didn't include this here, but the COVID-19 pandemic also exacerbated a lot of existing issues for a lot of people. But queer and trans students specifically, I think about how students we talk to who are queer or trans who were not out to their families, and then they had to go home and be with those families and either go back in the closet or be out and just not be in supportive environments. That has also led to a lot of increased incidences of distress. And I just published a paper actually with a journal, and we mentioned something about COVID, and they said, well, is that even relevant anymore to the review that you're giving? And we kind of fought with them a little bit about that. And it's like, well, sure, we're not in lockdowns anymore, but some students are still in university from when that was happening, and regardless, it still had a huge impact on the mental health of everybody, but especially queer and trans students. So I also did want to mention that as well. So we know that 2S LGBTQ plus students experience higher rates of emotional distress, and we know we just talked about COVID, but what are some of the other contributing factors? I'll briefly touch on most of these today. But broadly speaking, within the literature, these contributing factors include homophobia and transphobia. I'll also mention other forms of oppression like racism, colonialism, ableism, sexism, any type of oppression, discrimination and harassment, campus climate, which we'll talk about in a moment, family rejection, which I just briefly mentioned, violence, lack of support networks, and what's called minority stress, which again, I'll chat about in a moment. But the first major contributing factor that I want to talk about is campus climate. It comes up a lot in the research that we've done when we're thinking about like, why do people have these concerns? What are universities doing to try and address these concerns? A lot of the interventions are through campus climate. And so campus climate refers to the real or perceived quality of interpersonal, academic, and professional interactions on a campus and consists of the current attitudes, behaviors, practices, and policies of faculty, staff, administrators, and students concerning the level of respect for individual needs, abilities, and potential. Campus climate includes the experience of individuals and groups on a campus, and the quality and extent of the interaction between those various groups and individuals. I'll take another quote from a qualitative study by Evans et al., who write, "The university provides an environment that can either enhance students' education, life skills, and social involvement, or can hinder and isolate them. Therefore, it is imperative that post-secondary institutions work to address negative aspects of campus climate that could contribute to the isolation or the negative mental health of 2SLGBTQ plus students." So here's some examples of negative aspects of campus climate that can contribute to poor mental health outcomes. So it includes things like bullying, discrimination, social exclusion, name calling, which is amongst peers and faculty. Unfortunately, students reported offensive graffiti, physical abuse, and negative classroom environments. Again, another obvious factor, which we did talk about, was homophobia and transphobia, which still unfortunately exist on Canadian university campuses. A lot of the work that I've done has shown that students are still navigating these things in their personal relationships, online, in their communities, families, and I'll talk about that a little bit later. But for now, let's talk about some of the positive aspects of campus climate. Things that make 2S LGBTQ plus students feel safer and which could improve their mental health. The first being perceived level of freedom, which refers to the fact, students are leaving home for the first time and they're in an environment where they feel more free to not just, in terms of their identity, but to make own decisions about their life. There's the diminished restraint of high school norms, so they're getting out of the high school environment into a different place that is much bigger than their individual high school. They experience more social networks, so support networks, either through peers, classmates, student groups that are designed to support queer and trans people, supportive faculty and staff, of course, decreased emotional isolation, as well as anti-discrimination policies and programs. So not just related to gender and sexuality, but anti-racism policies, anti-ableism policies, and the like. And one of the other main areas of literature I want to talk about in relation to contributing factors, within the literature we see quite a bit about the application of minority stress theory to explain some of the mental health disparities. So this is from Frost and Meyer, and they define minority stress theory in the following. So they say, the foundation of minority stress theory lies in the hypothesis that sexual minority health disparities are produced by excess exposure to social stress faced by sexual minority populations due to their stigmatized social status relative to heterosexual populations. Minority stress is distinguished from general stress, stress that all people experience by its origin in prejudice and stigma. Thus, a stressor such as losing one's job could be a general stressor or a minority stressor, depending on whether it was motivated by prejudice against sexual and gender minority people, as opposed to the economic downtowns that impact everyone regardless of sexual and gender identity. So this theory was originally conceived of by Meyer in relation to sexual minority men specifically. But I would like to note that the minority stress model has been used in countless other ways to talk about people, any sort of marginalized group of people. Talking about racism, talking about ableism, all the isms. It applies sort of across the board. I'm just referring to its use in gender and sexuality here. So there's two specific types, or two different aspects of minority stress. So there's these distal stressors and proximal stressors. And these are quotations from Frost and Meyer's work. Distal stressors include stressors that originate from people or institutions that impact the queer trans person. These include discriminatory policies and laws, acute major life events like losing a job, being victimized by violence, chronic stressors like living in poverty, some of the more quote unquote minor or everyday experiences of discrimination, microaggressions, being treated unfairly, being treated with disrespect, or even what they call non-events, so which are the expected positive, people that are expecting to have positive experiences, which are then, quote, thwarted due to stigma and prejudice. And then proximal stressors arise from a socialization process in which sexual and gender minority people learn to reject themselves. And this will come up in some of the work I talk about later. They reject themselves for being LGBT, which means internalized stigma. They can develop expectations to be stigmatized due to the awareness of prevailing social stigma, so expectations of rejection, or they hide their LGBT identity as a way to protect themselves against the distal minority stressors, in which is referred to as identity concealment. Concealment is protective in some environments, but it also limits access to social support and affirmation, which complicates its role in minority stress theory. So in our own research, issues of minority stress were raised by a lot of the students that we interviewed. More specifically, despite narratives of social progress as it relates to the acceptance of queer and trans people, the students we engaged with recounted multiple experiences of homophobia, transphobia, and other intersecting forms of oppression, such as racism and ableism, which contributed to negative mental health outcomes, such as self-reported anxiety and depression. So, for example, one of the students in our study, Cooper, I have a quote from Cooper here. He told us the following. I would say as an adult, my sort of exploration of my gender started during the pandemic, which was parallel to just a general decline in mental health, as it was for a lot of people during that time. I still feel a lot of anxiety around how I choose to dress. If I do choose to dress in more of a socially feminine way, then I feel a lot of anxiety about leaving my house, which I'm trying to get over. It's weird because I feel like pre-pandemic, I was so unapologetic. And all through high school, like I was bullied, but I was never, diminished. I still did what I wanted and wore what I wanted. And pre-pandemic, I feel like I was just walking around in my heels all the time. And now I don't know what. I feel like I expected as I got older for the confidence to grow with me. And now it feels like it's doing the opposite. So like Cooper, and again, all names used in this presentation are pseudonyms. But like Cooper, another one of our participants, Leah, described fears of being visibly queer in public. So Leah is a white cisgender queer woman. She told us multiple stories of violence and discrimination experienced not only by herself, but those close to her. So for example, Leah's roommate, a trans woman, was stabbed, which led Leah to fear leaving her house with her trans ex-partner, as well as having fears about coming out as queer. So she told us, I know the fear. When I was with my partner and we were walking around, people would throw stuff at us on public transit. Yeah, it was scary. My partner would say, I'm not going anywhere without carrying a knife, like a switchblade or a pocket knife. She's never had to use it, but she told me, I don't feel safe. I need to have it. And that it just made her feel more empowered, just so that she could go outside. Leah also told us that she and her partner made plans to never go anywhere else without the other, and that they would make up plans for what they would do if they were being followed. They actually ended up developing code words to let the other person know if they thought they were being followed. And as Leah so poignantly stated, why do we have to live like this? I'll offer one final example here from a student named Max, a transmasculine person who also described a fear of being seen in public after they witnessed a traumatic incident following a pro-trans rally. As Max described, on the way back to the subway, I realized that I was by myself and very visibly trans. Some guy chased me into the subway station and was shouting at me like, God bless America, and marriages are between a man and a woman, and other random things. He chased me onto the subway and then he followed me onto the train. He pulled out a rosary and started praying over my head for the duration of the subway ride, and nobody did anything. There were people around me, but they didn't do anything. After that, I was really afraid to leave my apartment for a while. I was really shaken up. It got to the point where I was so afraid to leave. And here it's important to note that the three experiences that I've just explored with you, they didn't happen on campus. Um, except for an incident we'll talk about later. Um, a lot of these things were happening to students off campus in the community. But that doesn't mean that these experiences that they're having and the negative mental health impacts are not a post-secondary student mental health issue. Is students bring this stuff with them to campus, right? They're carrying these things with them as they're trying to navigate for what many of them is a new stage in their life. For a lot of people, university is the first time they even have the option of trying to access mental health care. It's complicated as we'll explore, but this is really a time where it's the first time they could be able to explore these things. And so any issues related to transphobia and homophobia and other types of discrimination are a post-secondary mental health care issue. And so we need to think about designing our programs, policies, and services to account for these types of things. To put these students' experiences into context, if we look at some existing data, there's unfortunate evidence that support for 2S LGBTQ plus rights in Canada is actually dwindling. Even though Canada has been a global leader, at least from a human rights perspective, including the legalization of same-sex marriage in 2005, and through the entrenchment of protections for trans and gender nonconforming people in the Canadian Human Rights Act. But according to a 2024 survey, support for queer rights and visibility has experienced precipitous drops in Canada. More specifically, the survey found that only 49% of Canadians agreed with people being open about their sexual orientation and gender identity, a number which has gone down by 12% since 2021. They also found that while 49% of respondents agreed with people being open, they still put Canada in the bottom 10 of countries measured. So there's a perception that Canada is actually not doing so well. As well, there was a 2018 survey on safety in public and private spaces by Statistics Canada, which found that LGBT plus Canadians, so lesbian, gay, bisexual, and anyone who's not heterosexual, were more likely to report being violently victimized in their lifetime and to have experienced inappropriate behaviors in public and online than non-sexual minority Canadians. So stories like Cooper's and Leah's and Max's demonstrate very real problems with being queer or trans in public spaces, despite these social attitudes. Whether their anxieties were the result of direct violence or a fear of violence, the problem remains that students are struggling with these things. And I really want to drive home the point that, we have made a lot of progress as a society, and there's all these narratives of social progress. Um, but still, like I'm presenting to you today about LGBTQ mental health, and I'm like, yeah, homophobia and transphobia are problems. Um, so they still very much exist. It's a really basic and probably expected finding for me to explain, but we need to really drive that home. So one of the last themes I want to explore relates to the experiences of students with on-campus mental health care services. And I'll talk about that specifically in relation to the work I've conducted during my time in the Dal Atlanta School of Public Health. Specifically, I want to talk to you about a paper my team and I have published. It's actually in the copy editing phase right now. Excuse me, so it'll be available soon. Perhaps I can circulate it when the time comes to everyone who signed up today. I just want to speak a bit about this paper and some of its contributions as a means of starting a conversation about how students experience on-campus mental health care systems, at least under very specific conditions. The background for this paper is, based on knowledge that over the past decade, post-secondary institutions have really experienced this ever-growing demand for on-campus mental health care services. Um, as we've talked about, there's been an overwhelmingly upward trend in the number of students that are experiencing mental health issues. And these concerning trends have placed pressure on post-secondary institutions to improve access to on-campus services. A lot of this pressure has come about due to tragedy. And universities are trying to be responsive to these things. But many post-secondary institutions have really struggled to hire enough counselors to meet the demand, citing tuition freezes, lack of sufficient funding to properly address the needs of students. And so, we initially didn't set out to study the specific system, but we came to it through the work that we did. Over the past several years, the Step Care 2.0 framework for organizing mental health care service delivery has emerged as a popular framework to adopt within this sort of context of austerity. It claims to have a large focus on accessibility, diversity of services, this person-centered philosophy. It's supposed to be more sustainable, and it's supposed to, increase access to services across the board. And so using qualitative interviews with 2SLGBTQ plus students, we sought to understand how their experiences under such a framework are impacted by its organizational structure. So more specifically, we look at the model's self-promotional claims to accessibility by showing how in a lot of cases the structure and the underlying ethos actually inhibits certain groups of students from getting the care they need when they need it. And while, multiple universities have claimed, and we don't doubt this to be true, that wait times for services have been drastically reduced or even eliminated, which is a really key important step in trying to improve post-secondary mental health care services. There are still questions around, okay, well, if these services are more accessible, but what are the quality of those services? Students are accessing more care, but what type of care? And does that care actually help them achieve the mental health goals that they're setting out for themselves? So specific research questions based at the University of Toronto. So to what extent are mental health resources at U of T meeting the needs of 2SLGBTQ plus students? What would a student-informed approach to mental health care look like? And how do intersecting axes of oppression such as racism, sexism, classism, and ableism compound the mental health issues of 2SLGBTQ plus students and or how they access care at the university? Some of you here might already be familiar with and understand the Step Care 2.0 model. I know that CICMH has some resources on it. The Mental Health Commission of Canada has some resources on it. But in case anyone's unfamiliar, I do want to give a brief overview for the sake of clarity. So at its core, StepCare 2.0 is a model of mental health service delivery and organization that seeks to effectively reshape the way we think about mental health care and emotional well-being. It's been described as a culture shift and an ecosystem that claims to be increasingly accessible, person-centered, and recovery-oriented. It's described as being rooted in principles of social justice, informed decision-making, open access co-design, and recovery-oriented practices, with an emphasis on ensuring that people get access to the type of care they need when they need it. It's an adaptation of the original step care model used in the United Kingdom, which sought to reorganize mental health care in a more efficient and sustainable way within the context of limited resources, which is the context within a lot of post-secondary institutions are operating. And so through providing a diversity of services and by offering the least resource-intensive programming first, it's designed to be a much more accessible system. But where StepCare 2.0 differs from its predecessor is in its organizational logic. So the UK model operates on a continuum of symptom severity, whereas StepCare 2.0 is based on a continuum of readiness. So as the steps of step care increase, and I'll show the steps in a moment, so does the intensity of the treatment. The idea is that someone with severe symptoms but who is not ready for intensive treatment would be offered lower intensity mental health resources first, such as self-directed e-mental health resources or peer support. Conversely, someone with quote unquote low symptoms of severity but high levels of readiness may be offered more intensive care. And the logic is that by providing students with a variety of services, ranging from self-directed to crisis care, service users will be able to find something that meets them where they're at. Here I have a graphic of the 9 steps that step care is organized around. Some of them might look a little different depending on the institution, but they're organized ranging from least intensive to most intensive. So it starts with least intensive, informational self-directed, then interactive self-directed, peer support, workshops, guided self-help, intensive group programming, flexible intensive individual programming, chronic care, and specialist consultation, and acute and crisis care. So you see, as on the right here, this is as the investment in readiness goes up, so does the level of care. And at the bottom, there's an arrow pointing from 9 to 1, sort of from right to left. And that's to show the level of autonomy that people have. So the students will have the most autonomy at level 1 and 2, and the least amount of autonomy at level 9. And students, I should say, you can access multiple steps simultaneously. And the idea is that students can move up or down depending on what they need. We have some evidence that suggests maybe that's not always the case, but I'll get to that in a moment. What we're really focusing on in this paper is these discourses of accessibility. Under this StepCare 2.0 framework, all the literature that we've looked at, accessibility is defined as people getting the care they need when they need it. And this is a very important phrase to remember as we continue. The design of StepCare 2.0 purports to facilitate increased accessibility in several ways, including through providing a range of different interventions, building the infrastructure for same-day or next-day counseling, connecting students to online text-based and phone-based resources that can be accessed from the comfort of their homes. And this diversification of services is a very important aspect of the model. Increasing the types of services a student can access means that they always have something they can access, even if they're waiting for a higher level of service. One of the ways that the model tries to make care more accessible, and I'm not sure that this is integrated in every system, but it's a big feature of the consultation process when working with institutions that might want to explore this secure framework is through the mobilization of a one-at-a-time therapy model, sometimes referred to as single session therapy, although some would argue that's a misnomer, which is a drop-in counseling model developed by Moshe Talman in the early 1990s. And so under this model, as opposed to a traditional therapy model, which you might see a therapist for 50 to 60 minutes weekly or biweekly. In this model, every session is self-contained. It has a simple brief assessment and an intervention and an evaluation on whether the intervention was helpful. It's provided ideally on a same day or next day basis to help students identify immediate concerns with the idea that one session is often enough. And that is also another key phrase to remember as we go forward. In all the research that we've done, including the literature on step care, both in academic literature and the gray literature, and talking to people from University of Toronto and other places, we understand that this model does work well, or likely works well for quite a few people, reducing or eliminating wait times, helping people with immediate problems. It's a very admirable feat. It's a step in the right direction. We don't want to suggest that it's not working at all. But we have seen in our work that especially this emphasis on the one at a time model, the short-term therapy, which is a feature of where we did our study. It's kind of complicated when we start thinking about demographics, especially in our case, 2SLGBTQ plus students. And so in what follows, these discourses of accessibility that characterize this model is going to come into a bit of a critical focus. Again, it's not to argue that this model is wholly inaccessible, but rather we just really want to add nuance to these discourses of accessibility that have contributed to the popularity of this model. Earlier, I mentioned the phrase like students getting care they need when they need it. But as our work has kind of shows, not all students can get the care they need when they need. Some of them might get the care that they need once, but then not get it again when they need it. Or they might be able to walk into counseling and get an appointment, and then the service that is actually rendered to them doesn't connect with them at all. So we're really just trying to draw attention to some of how these underlying logics are complicated, focusing on both those claims to accessibility about care they need when they need it. And here I'm going to focus on 3 different stories from 3 different students. Again, the names are all pseudonyms, to sort of talk about what I mean here and to show how these questions are ultimately queer and trans issues. So the first story I want to share is from a participant named Ruby. Ruby uses he, she, and they pronouns. They're an international student from China, which will become important in a moment. Ruby experienced sexual assault on campus and was able to speak with a mental health professional who diagnosed them with depression and post-traumatic stress disorder. They met with this provider a few times, but quickly they were told that their appointments with their psychiatrist were coming to an end. They were told they had reached the allotted number of sessions, which was not predetermined to them, but that they would still require care elsewhere because, quote, their issue involved trauma. However, Ruby was given no assistance to ensure the continuity of their care. Instead, they did a lot of the work themselves. They navigated lists to psychiatrists on several websites, compiled contact information, emailed and called providers asking if their services were available, only to be met with non-responses or long wait times. Eventually, Ruby did find an off-campus psychiatrist, but the process was far from easily accessible. And when we talk about students' experiences with off-campus services, it can be easy to dismiss the difficulties that they have with those off-campus, public or private services that are not connected to the university. But these discussions are actually quite relevant, given that in a lot of cases in the post-secondary context, Step Care 2.0 relies on community-based services as an extension of what the university can provide. Because of course, the university can't be everything to everyone. There will be systems that students have to be using outside of the school. But then if the model is, if the public and private systems off campus serve as an extension of your campus-based model, facilitating access to these services is actually a really important part of step care. Ruby also spoke about difficulties trying to access specialized care as an international student. So they were suggested to try a form of treatment called eye movement desensitization and reprocessing, or EMDR. It's a type of trauma therapy, some of which is publicly funded. And Ruby sought these programs out, but discovered that they wouldn't accept the university health insurance plan that international students must adopt, which is the alternative to the Ontario health insurance plan that residents of Ontario are able to benefit from. So they were referred somewhere, told it would help them, and then they arrived there and they said, oh no, we can't take the form of insurance that you have as an international student. Another example of how care can kind of be compromised within the specific framework comes from Jude, who uses they, them pronouns. They're a queer and lesbian non-binary undergraduate student. They initially sought out counseling through their specific college, concerned about feelings of depression and thoughts of ending their life. That prompted them to seek out this care. They really wanted help processing these types of feelings. They wanted to understand where these feelings were coming from, why they were coming up for them, and then how they could, properly address that. They were able to access these services. They were able to find somebody online, which on campus, I should say, which is step one. But they weren't necessarily able to find the type of care that they needed. And so the fault line in Jude's story, the fault line that their story exposes is concerned with the lack of sufficient support for their specific needs. And Jude overall described their experience with counseling to be both troubling and insufficient. And so instead of being able to explore the deeper issues that they were dealing with, as they had hoped, their experience was much different. So Jude told us the following. I expressed to them that I was having like suicidal ideation and stuff. Every session would start off with them asking me if I had a plan for suicide. Basically, I'd be like, I don't have a plan. It sort of felt like, that box had been checked. They're not going to kill themselves. Okay, we can move on. It almost felt like them trying to make sure they didn't have a suicide in their residence more than actually trying to help me. And Jude's case is particularly troubling, given that a lot of the broader push for increased access to services occurred within the context of tragedy. And of course, it would be unreasonable to suggest that their counselor's inability to address the root causes of their concerns is part of the step care model, like that no model can account for the capabilities of the practitioners. But at the same time, it's not unreasonable to suggest that this emphasis on one at a time short-term counseling can fail students who are looking to do a deep exploration of their suffering. And a lot of times those are students who experience marginalization, queer students, trans students, racialized students, disabled students, first generation students, international students. So these little failures kind of build up over time, and that's sort of the picture we're trying to paint here. So when we're talking about challenging this one at a time or short-term counseling, again, it likely works for a lot of people. It just so happens that the people we spoke to, it didn't quite work so well. This logic, this buying into this specific model, is based on a lot of research that's by the proponents of step care. that up to 80% of people seeking care will only attend a single session. This is also tied up in the logic that the majority of people aren't ready to do the work of long-term therapy, which may be true. More specifically, in relation to post-secondary students, so Cornish et al., Peter Cornish is one of the founders of Step Care, has really done so much work, has published so much work on where this model comes from and why. And in one of the articles that we read specifically about Step Care and students, it was being argued that traditional psychotherapy models, so seeing someone regularly for longer sessions, did not fit the lifestyles or needs of today's students who live much of their lives online and expect immediate solutions. So the model is justifying focusing on short-term therapy, relying more on e-mental health services, kind of at the expense of allowing students with higher acuity mental health issues, the chance to explore the sources of their distress in a more comprehensive and ongoing manner. There's this like imagined subject of the student who is unwilling, unready to engage, not really interested in going to therapy, which students like Jude really effectively disprove. And I really would like to underscore here that every single student we talk to, whether they access on-campus mental health care or not, we're extremely motivated to find support and not just, online or over the phone. We had students who actually had terrible experiences with those services. They want to connect with people. They want a counselor. They want a psychiatrist. They want to really engage with a person, and they want to explore their issues, and they want to make changes in their lives. And this isn't to discount all the research that's been done on the effectiveness of single session therapy. We just are curious about how this emphasis might leave behind certain students who are often, marginalized in some manner. The final story I'll talk about in relation to our paper is a story from Annie, again, focusing on how this system kind of produces in some way inaccessible structures. And so Annie was a student who was already, quote, in the system. She'd already been to her initial counseling appointment. She had gone because as a Black and Asian queer woman, she had experienced incidences of anti-Black racism actually within a queer space on campus, so a space where she felt like she was safe, but this racism was directed at her by one of her queer peers at a queer space on campus. So like I mentioned, the day she went to counseling, she was able to find somebody within hours of arriving, saw somebody that same day. She was matched with a therapist who could really relate to her experiences of anti-Black racism, who provided her with helpful strategies to cope with, anti-Black racism, the trauma of that, alongside some other mental health issues that Annie had that were pre-existing. But even though she was able to access the care that she needed, especially initially, she couldn't always get it when she needed it. And so under this sort of one-at-a-time structure, follow-up appointments aren't really necessarily booked. So for Annie, she was told that she could not book back-to-back appointments, meaning that they would not be scheduled at regular intervals, but rather on a basis of need. So she was assured that she should call counseling services on the day that she felt that she needed help, and was told that she would be able to be matched with her counselor the day that she needed. However, this promise did not always materialize. She described it as a day where she'd actually seen her abuser on campus, which led to intense distress. She called counseling looking for an appointment, but was told that they were unavailable. And as she told us, I thought I had to go to the hospital that day because I kept spiraling. So in this example, the promise of same-day access is complicated by the actual structure of this one-at-a-time single session model, where a limited number of sessions are available per day, and the goal is to focus on immediate concerns. And so students like Annie, even though they are, quote, in therapy, they still have to follow the same day booking structure. They're still competing with students on the day of who feel like they need to talk to a counselor. And these back-to-back appointments, I've heard from some students that it is possible. It's just not as common. Um, I think it probably depends on the provider, but in Annie's case, they were like, no, we're not going to book another appointment. You just call when you need us, and apparently we'll be there. Um, and of course, for students who would benefit from this single session, same day model, it's appealing. They don't have to wait on a list for an issue to be met to talk about an issue that could be solved by a brief intervention. But again, students like Annie, students like Jude, students like Ruby, they have higher acuity mental health problems that can require more consistent care. They're experiencing a lot of stress, trying to get what they need. And I think so we talked about how Ruby accessed off-campus care, but for Jude as well, they eventually were like, I just went off campus and now I pay out of pocket, which is not ideal. We're coming near to the end now. I just want to talk about a couple gaps in the research, and then we can go into questions. So the first gap that we've noticed is a real lack of literature on the experiences of Two-Spirit, Indigiqueer, and LGBTQ plus Indigenous university students. So to be clear, there is work about Two-Spirit, Indigiqueer, and LGBTQ plus Indigenous young people. And so we can draw from a lot of that research and can apply it into the student context. Margaret Robinson talks about some of these disparities, like high rates of poverty, violence, PTSD, anxiety, and depression. The Trevor Project has quite a substantial document that talks about mental health disparities amongst this group. And again, all that research is very relevant. But as we talked about earlier, when we were talking about campus climate, we know that the university is a very specific context that produces certain types of mental health concerns. So if we want to be focusing on Indigenous students, we need to be producing a little bit more work within the university context. Just because it's in the academic literature doesn't mean it's not happening. There's work that is being done outside of academia, but it's still worth bringing up the gap. And finally, there was a lack of tested interventions. So we did a scoping review as part of this project. We wanted to see the types of interventions that were being produced. Our search had over 2,000 results, but eventually only 6 articles were actually selected for inclusion. And of course, there's research that talks about types of interventions that should happen, but there's a lack of them that are actually tested. So that concludes the main substance of the presentation. I want to talk a little bit about what's next for me and my team, which is basically we're opening the project up. We're looking at multiple institutions. We're looking at the experiences of all students, of course, with an attention to gender, race, sexuality, marginalized groups of students. And we'll be working with an interdisciplinary team across different universities in Canada. And of relevance to, I think, a lot of you that are here today, we're really looking to engage more closely with healthcare workers, key decision makers, so administrators, directors of wellness, etc. So I'll have my contact information at the end. And then just before I conclude, I want to thank Inlight Student Mental Health Research, which is an institutional strategic initiative at U of T, who supported this research with additional support by Daniel Grace, my supervisor, through the Canada Research Chairs Program. And really would like to thank all the students that made this possible, so the students that informed our advisory committee, the students that we interviewed, and as well as the students who worked on this project with us. Thank you.
Thank you so much, Sarah. This is really great, insightful presentation, and I know everybody else appreciates all this information as well. While we're waiting for any questions, I do notice that we are a minute away from lunchtime. If folks can remain, that's fantastic. If you have to leave, that's also fine. We do record this webinar, so you're welcome to check it out later. Maybe Sarah, maybe you can talk a little bit more about what you're planning to present for our conference.
Right. So, as a part of the conference or as a part of the project, we produced a report that had a series of 5 recommendations that the university could implement to better support the mental health of queer and trans students. So it was in the context of U of T, but it applies, I think, more broadly to a lot of institutions. So we talked about some of the 5 key issues that students face and then different potential solutions. So things like students don't know that mental health care exists at the university. They don't trust that the system is going to work for them. They don't trust they're going to meet a queer counselor, things like that. And I'll be presenting on it with one of my students who worked very closely on the project, actually. So it's a little bit more of a practical session. I didn't want to, I wanted to kind of include some stuff on it today, but it was gonna be too much of a beefy presentation. And I figured since it's happening in November, folks could come if they're interested.
Yeah, I'm really excited to check it out. We do have one question here. So it says, for queer mental health practitioners doing this work, it is exhausting to continuously advocate for changes needed in policy and systems.
Mhm.
If you were to name one key thing that these students would change to improve services, what would the next single best change be?
Mm, yeah, I mean, my impulse, and this is such a huge thing to do, but it's really, there's such a culture of distrust. Students, there were many students who did try to access services, but there were a lot of students we talked to that like, I don't trust that they're going to be able to help me. I don't know that I'm going to be met with somebody who understands my gender identity. What if they don't use my pronouns? Like, or again, a lot of queer and trans students have experiences of trauma, not just, Annie, like we talked about, or, Ruby and Jude as well. But um, and they don't think that the university can help them process those types of things. They don't see it as comprehensive enough um, to really help them like process like deeper experiences of trauma, which a lot of students have. I think and you're right, it is exhausting. It is exhausting to do this work as a queer person and to see things not change or only change incrementally. But I think it's really about developing this culture of trust. It goes back to campus climate. It's all interconnected and it's a big thing, but yeah, the biggest thing is there's a lack of trust, I think. How we build that is another question. I mean, that's something we want to know more about, but yeah, there's a big lack of trust.
For sure. And maybe that's another call for action
Mhm.
for post-secondary institutions that,
Mhm.
these are things that they can potentially, you know, kind of look into, kind of build programs, build initiatives to build that climate.
Mhm.
I have a question here in the chat. Any work specifically on supporting queer and trans Muslim students on campus,
Hmm.
like how to manage religious expectations versus identity awareness?
That's a really good question. In the work that we've done, I haven't come across it. It doesn't mean that it doesn't exist. Um, there was some research that talked about the intersections with religion and gender identity, but that was related to Christianity, which is obviously different. I can look into that. There must be something that exists um, that talks about that. Although we did note it was a limitation I didn't really have time to get into, but there is like a lack of intersectional research. Not that it doesn't exist, like there's certainly research that exists, a lot that talks about the intersections between gender and sexuality and race. Um, based on all the work I've done, I'd still like to see more of it. We're trying in our work to really break that down. The majority of students that were in our study were students of color, racialized students. And so, but there is still kind of not seeing as much as I think there probably should be. But yeah, as in relating to queer and trans Muslim students specifically, yeah, I haven't seen anything, but again, it doesn't mean that it doesn't exist. It's a good question.
I'm not seeing any other. Oh, just kidding. I think something popped up. Oh, here we go. What does intersectional research mean exactly? How do you feel this limitation impacted the research?
Right. So my apologies for just dropping a term. So intersectionality, it's an approach to doing research. To put it very simply, there's a lot of nuances I could talk about, but it's basically an approach, and it's used a lot within healthcare to understand how people who experience multiple marginalization, so someone who is gay and trans, racialized, disabled, like people whose identities intersect across different experiences, um, how those intersections impact their health. So, like a Black trans woman is going to experience racism. She's going to experience misogyny. She's going to experience transphobia. And so we have to think about all of those things when we're thinking about that person's experience. And homophobia is grounded in colonialism. It's grounded in racism. It's grounded in these other forms of oppression. Um, and again, so we have to take these things into consideration. A lot of the research that I have reviewed, again, some of it does talk about race, but a lot is about sexual and gender identity. Some studies are even about just about sexuality. There's an article was reviewing again yesterday, and they were like, yeah, we talked to trans students, but we had to kind of exclude them from this because the data they had was very particular and it's not related to the present issue. Um, and I have seen more of a growth in research on trans students specifically, but even that sometimes isn't even considered. So it's about looking across different aspects of identity, different axes of the relative degrees of power and privilege that we all experience. And again, there is research. I don't want to make it sound like no one's doing this. Um, but that's what we talk about here at the center all the time is like, how do we make this more intersectional? How do we forward these types of perspectives?
Yeah, thanks so much, Sarah. I do want to be mindful of the time for you as well as for attendees. It is lunchtime, so we will end our session here, but I do want to extend my appreciation to you, Sarah, for doing this presentation. Very, very much appreciated. Thank you for everyone who has attended. And please check out our website for any resources and the recording that will be put up later today. And we will have our next webinar on November 27th regarding using plants and plant materials to support student well-being. It's going to be a fantastic webinar. I'm really excited. I've seen that presentation before and I was very much inspired by it. So I invite folks to check that out. Yeah, and I guess thanks, folks. We'll end it off here, and I hope you have a good rest of the day.
Yeah, thanks everybody. I guess I'll sharing my screen now, but thanks everyone for coming. Thanks again for inviting me. It's great to be here.